when John gave me this topic about how do I treat advanced bladder cancer in 2015, because I figured I could do this pretty quickly, which was not much different than in 2000. So thank you. I'm here all weekend. Um, that being said, I think the winds are changing. I think that this is a disease where clearly things are changing very rapidly, and we need to begin to think about them. And I think the way we need to start thinking about these things is to start thinking a little bit about the pathophysiology and the oncogenesis of this disease. And it's been recognized, I think, for a long time that this cancer develops along two different pathways. There's the upper pathway here that really is the urothelial hyperplasia, the TA disease. This is the warty disease that the urologists treat. For the most part, it is a hyperproliferative problem that is not clinically significant for patients aside from bleeding and the need for cystoscopies. However, a proportion of these cancers do progress onto that lower pathway, which is more nasty and real cancer, at least real cancer as far as an oncologist is concerned. That lower pathway develops along a CIS dysplasia pathway and is really characterized by initially alterations of P53 and RB and the other alterations that are recognized here, and many of the people here in this room have contributed to this knowledge. I think that what's important here is that we think about these as very different, and just because something is confined to the bladder does not make it, quote, superficial. It is a very different disease, whether it's a papillary hyperproliferative or a carcinoma in situ, quote, real cancer. I think the other part that sort of struck, the other data that sort of struck me was some data from last year, which was a cluster analysis that looked at a bunch of expression profiling papers and basically took all the data from a number of different malignancies and tried to recluster the cluster, so to speak. And here that top row is bladder cancer, and interestingly, it sort of divided into three clusters, and other people have done this with bladder cancer, have characterized 2 to 3 different clusters of cancer, and here similar 3 clusters. But I think what's interesting here, in analogy to other diseases, is that that first cluster was very closely related to adenocarcinomas of the lung. There was a second cluster which was very much closely related, at least on a hierarchical clustering profile, to head and neck squamous cancer and squamous cell cancer of the lung. And then there was a third cluster that sort of lived by itself. So I think that we're beginning to get into an era where not only does histology and organ of origin matter, but the molecular phenotype does matter, and the molecular phenotype does extend across different organs of origin, and I think we need to begin to pay attention to this, and I think we need to begin treating patients in this manner, and it's not just whether the cancer arose below the diaphragm or above the diaphragm, but perhaps whether it arose in a smoking environment or in a non-smoking environment. I think that the other thing that's happened over the last couple of years from a clinical standpoint is that combined modality therapy and organ preservation has become a little bit more of a standard within the clinical realm. It's always been a standard across the pond, I think, in Europe, and it's been sort of slow here in the United States, aside from that pocket in Boston. But I think that this is not the case for other diseases where organ preservation becomes a real issue, and I think we have to recognize that a native organ is way better than anything that our surgical colleagues can reconstruct. Here are some of the long-term outcomes, and I think that we just have to recognize that long-term outcomes with organ preservation approaches are very similar to what we see with surgical approaches. And we actually have level 1 data now, once again, thanks to some of our colleagues in Europe and Great Britain. Here is a trial of combined modality therapy with chemo-RT versus radiation alone, and there's clearly an improved survival if you use combined modality therapy. Now, the interesting thing about this approach is that our colleagues here use the combination of 5-FU and mitomycin C. Most of us in the urologic fields don't even know what mitomycin C is because we used that once when we were as fellows and then forgot about it. But it is an approach that's used in GI malignancies, and it does work. So what about some practical issues? Neoadjuvant chemotherapy prior to combined modality therapy. I think it's controversial, but most of the consensus falls on the no side. Which chemotherapy do you utilize? Well, I just said that the mitomycin C and 5-FU, that should be a U, not an R. My finger was a little bit quick on the right rather than the left. It has the best randomized data, but it can be tough on some of our elderly patients. Cisplatin has been long used as a radiation sensitizing agent, but no level 1 data. And low-dose gemcitabine has also been used by some individuals, but there's more limited data. There are some clinical features that predict good outcome: complete transurethral resection of the tumor, clinical T2 disease, and the absence of hydronephrosis at the beginning of therapy. I think we all have to recognize that if one does bladder preservation, that native bladder remains at risk for oncogenesis, and there is a 20 to 30% risk of non-muscle invasive recurrence. What about perioperative therapy? I think that this is a little bit of an embarrassment. The dean looked at some of this. This was an article in the New England Journal of Medicine, that schlock journal that nobody reads. 317 patients, enrollment in 1987 to 1998. So this trial enrolled before I went to residency, completed a long time later, and was then reported with a follow-up of 8.5 years. This is the survival data. There's real survival data. Well, you know, maybe it's not so great, it's just a little bit, yada, yada, yada. It's at least as good as the perioperative chemotherapy data that we see with breast cancer, with colon cancer, with any one of our other solid tumors. And we know that there's a predictive marker following therapy. So for those patients who have a PT0 following neoadjuvant therapy in those upper curves, they do quite well. And the rate with a PT0 is about close to 38% with neoadjuvant therapy. And if you don't do anything except a TURBT, sometimes you can get it all with just a transurethral resection, and you do see some patients like that. And yet, it has not been implemented. There's lots of data to this. This is, you know, since this paper was published in 2008, there's been some additional data that suggests it's maybe a little bit better. But here's 240 patients, radical cystectomy for bladder cancer. 145 of these had a T2, a clinical T2 disease. Of those, 17 received cisplatin-based neoadjuvant chemotherapy, 17%. And the renal function was adequate in 2/3 of patients. So theoretically, 2/3 of patients could have gotten it, 17% actually did. And the reason, and the lack of implementation of level 1 data, I think, is one of the major problems in our field. Now, there's been this long-acting debate. I've been at this debate for the last 15 years of my career of neoadjuvant adjuvant therapy. You can read this. The people in this room know this data. And to me, this is actually pretty simple. There's a major disadvantage with adjuvant therapy, which is that the survival benefit has not been established with level 1 data, lots of correlative, lots of associated data. I think we believe it. We all believe. At my university, we say we believe in God. All others must bring data. But there's not been level 1 data. And those patients, we know, are less likely to receive intended chemotherapy in the adjuvant setting due to postoperative performance status and complications than in the neoadjuvant setting. So I think we have to recognize that in the treatment of our patients, that this is a standard. Ain't a great standard, but it's standard. Now, I'm from the land of Lincoln, so 10 years ago, MVAC was first reported. Not in the land of Lincoln, but from that other small town of Manhattan. Gemcitabine was first developed, it was reported to have activity in 1997. I did this with Paul Ward when he was in Lilly. We both were, less gray hair or had hair at the time. That we found that the combination of gemcitabine and cisplatin was similar to MVAC. Response rate similar, median progression-free, overall survival. So all very similar. Carboplatin is likely a little bit less effective than cisplatin in the metastatic setting, but whether this is truly clinically relevant in a disease where cures are few and far between, I think can be questioned. What about tubule inhibitors? We all do it. Pick your favorite tubule inhibitor in second-line metastatic disease. They all have response rates of 10 to 20%. I didn't bother listing them all. We've all participated in the phase 2 studies. There is one phase 3 study. It was vinflunine versus best supportive care. No chemotherapy. We just treated the patients well. Here's the survival curves. No difference. One does not need to be a crackerjack statistician to detect that there's no difference here. For reasons that are beyond my understanding, the Europeans decided that vinflunine was therefore approvable for utilization. The Canadians and the U.S. regulatory agents actually looked at the curves. But things are changing. We heard a little bit about the PD-1 pathway inhibitors. Here's some of the data with atezolizumab and looking at PD-L1 and PD-L1 specifically in the immune infiltrating cells as a predictive marker. There's similar data with pembrolizumab. I think we'll go over some of this in the weekend. Clearly, we're having real impact in even refractory disease with these agents. There's a number of phase 3 trials now in process. I mentioned 2 of them. In the refractory setting, there's a phase 3 trial, pembrolizumab versus paclitaxel or vinflunine. There's a similar trial with atezolizumab, and there's even adjuvant trials now going on, and a whole slew of phase 2 single agent and combination trials with every drug company's PD-1, PD-L1 inhibitor, and in combination with other immune stimulating agents. So how do I treat bladder cancer in 2015? I think for locally advanced disease, I'm much more likely to utilize combined modality therapy, I think, than I did earlier in my career. I still prefer neoadjuvant versus adjuvant cisplatin-based chemotherapy based on level 1 data, but I think we need to watch this space for PD-1 pathway inhibitors. They may actually have a real role even in this stage of disease. For first-line metastatic disease, gemcitabine cisplatin is for good prognosis patients, gemcitabine carboplatin for cisplatin ineligible patients. You pays your money, you takes your choice. And for second-line metastatic disease, I think that palliative care clinical is the standard of care. So there is nothing else that has been demonstrated to work as of today. So if you're going to be honest with yourself, you're going to be honest with your patients. For patients with progressive disease after first-line cytotoxic chemotherapy, palliative care is the standard. Clinical trials are appropriate. I think that PD-1 pathway inhibitors are relevant, and I think we're going to continue to need to subdivide this disease based on its molecular phenotype in addition to its organ of origin in order to select appropriate therapies. So I'll end there with 2.5 minutes to spare.